Good afternoon, ladies and gentlemen. I'd like to call this meeting to order. This is a Board of Trustees Insurance Committee meeting. With that said, we'll go ahead and jump to item 2, opening remarks. Dr. Montoya.
Dr. Escobedo, members of the board, audience, this is a meeting obviously that's very important for our district and for our staff because it covers all avenues of not only sharing information but trying to understand all of our insurance components. And obviously our employees come first, not only because of what they do and payroll, but support areas such as insurance and benefits are very, very important. So hopefully today we can share information, update everybody, allow a few questions, and move forward.
Thank you very much, sir. Moving on to item 3, this is an update on personalized prevention programs. Dr. Montoya.
Again, Dr. Escobedo, members of the board, Mr. Garcia, if you'd like to go ahead and begin, please.
Thank you, Dr. Montoya, Dr. Escobedo. We're going to go ahead and get started. Hopefully this afternoon we'll cover many topics. Some of it is just going to be some of the history of our usage on our plans, and then some of them are going to be some new ideas that, better? Yes? Okay. Some of them are going to be some new ideas that we would like to explore in the near future to try to enhance our insurance offerings to our employees. So with that being said, I'm going to ask Ms. Trevigny to come up to the mic. She's going to be introducing our presenters for personalized prevention. I'm also going to be interchanging with Mr. De Leon. So we're going to be working, this is our first time working together on a presentation for in front of our school board, so bear with us and we'll try to be as seamless as possible. So with that being said, Mr. Rigney.
Good afternoon, Mr. President, members. I'm going to introduce Kathy Corder. She's going to be doing the presentation for personalized prevention this afternoon. With her is Jacob Gray, who is their Chief Financial Officer. I really didn't have much of an introduction other than they've got a report that's included in your handouts. And with that, I'll call Kathy Corder to the mic.
That's just the 2 pages. That's the wrong. That's not the full. Yeah, I have a flash. Thank you. Thank you. Technical difficulties. One moment, please. Stand by. Now we've got her up. Good afternoon.
Good afternoon.
It's great to see all of you, board members, again, and Superintendent. Thank you for allowing me to share some time with you this afternoon to go over the Wellness Screenings Report Overview for 2012. It's been our great pleasure to work with you guys over the past few years, and so what I want to do today is really kind of look at the numbers from the last health screening that we did for the employees. Talk about some of the findings. We also have some metrics that look at some of the trends or things that we've seen change over the 3 years that we've been doing screenings for the district. So let's jump right in. The first slide really is just to illustrate that you're really the district should be commended. You're following the lead. Most companies, about 80% of middle and large-sized companies, are offering wellness initiatives. And really, there's a lot of reasons for that. One is obviously you guys have supported your employees here at the district and want to offer an opportunity for them to improve their health. But also, it's a good business decision because we want to try to control costs, catch some of the chronic conditions early, mitigate some of those things, which again can really help you as it relates to your health care costs overall. So from between February and April of 2012, we came on site to every campus, all the departments here at the district, and we were able to offer screenings. We screened a little over 5,000 folks, which is a tremendous turnout. For those of you that have heard us give our reviews over the past 3 to 4 times that we have provided screenings for your population, each year we catch more folks and are able to drive them and get them to participate in this important initiative. 71% of those participants were female. 29% male. Obviously, that follows the demographic of the district in and of itself. There were about 255 of those that we were, they already had lab work done recently, and so we just took height, weight, waist, blood pressure. But by, again, looking at these metrics, we were able to identify that the 2 key target priority areas for the district going forward is diabetes and prediabetes or metabolic syndrome, and then weight management, obesity. And again, I can tell you across our book of business, these are obviously issues that most companies struggle with, particularly in Texas. So that's not necessarily unique to Brownsville specifically. The other thing that we like to do is really kind of give you a report card, if you will. So how does Brownsville ISD compare to some national statistics on some of the metrics? And what you will see is actually, and this is CDC data that we're comparing it to as a benchmark. You're doing pretty good as it relates to cholesterol. But blood sugars, and I want to point out this is not necessarily the percent of folks that have diabetes here at the district, but rather the percent of folks that were identified as having high blood sugar at the time of the screening itself. You're running at about 3 times what we would expect to see, again, from CDC data. Again, illustrating that point that this obviously clearly is still a major priority area. Blood pressure, you're just slightly over what we would expect to see at 16, a little over 16%. Actually, of the participants had an elevated blood pressure reading at the time of the screening. And then finally, on the obesity metric, and using the criteria of a BMI at or above 30, which is, again, the kind of the watershed point for where weight starts really increasing health risk. And you can see that almost 46% of those participants were at or above that metric as well. So while, one thing I will say, I think in some of the future slides that I will show you today, there's been some improvements made. There's still opportunity for more improvement. And definitely, again, this can impact cost on the bottom line as well as quality of life for your employees. Another thing I'd like to share with you that we capture as we're going through the screening process is we're able to capture what we call critical alerts. So that is when we have a metric or a laboratory test that meets a certain threshold, a high-risk threshold, that the lab actually sends us the results very immediately. We reach out, get in touch with the member or the participant immediately, get them channeled to the right place, whether it be their physician's office, etc. And so I wanted to just kind of share with you some of those high alert findings. You will notice under body mass index category there were 441 folks that had BMI, or the body mass index rating of morbid obesity, which is, again, significantly increasing risk. Now, these are not folks that we necessarily reached out on the phone to and called as an alert, a laboratory alert, but these are definitely folks that at the results sessions, when going over those results with folks, our health coaches were certainly giving them guidance and counseling on the importance of working with their physician and or other resources in the community to work on the issue of weight. Triglycerides, another one of the blood fats. We had over 100 folks that had triglycerides anywhere from 401 to over 3,300. And a normal triglyceride is 150. So you can see there was a number of folks that had really high readings in that particular area, the highest of which was at 3,300. And I can tell you that particular individual, that was a big find, a big save. This was not an individual that had any prior knowledge of having an issue in this area, and they were able to get to the doctor and seek treatment pretty immediately, and that could have been truly a kind of a life-changing catch. Again, kind of going on down, cholesterol, you can see we didn't have that many folks that had alert cholesterols, but still there was a few. Same thing with the thyroid screening. Hemoglobin A1C, I will draw your attention to that. That's a 3-month average of what your blood sugar management is running. And so we did have some folks that were out of range. So what that's telling us, that these folks either are previously known diabetics and not managing their diabetes ideally, or these could have been folks that were unknown, that were undetected prior to the screening. Again, these individuals are, not only do we have the health coaching that really visits with them about diet and exercise and all of those sorts of things, but in medication compliance, but again, referred back to their physicians and or endocrinologist for follow-up, which again is an important catch. 77 folks had high blood sugars above 250, and I point this out because we had one individual who, through the screening, had a fasting blood sugar of 472. That's very, very, very critical. The individuals that had the really high readings on the blood sugar were again funneled immediately to their physician and or urgent care, as the case may be, for follow-up. Again, that particular group of individuals, that could have been something that really made a huge difference and impact on their quality of health and life with those catches. And then finally, blood pressure, and you can read through some of the values, the highest of which was 236 over 110. Again, that's in what could potentially lead to stroke range. And these folks, obviously, we knew their blood pressure the actual day of the screening events, and those folks were referred immediately, and some of which went at that very time to their doctors or the minor emergency clinic as the appropriate step would be. If we kind of talk about just the critical alerts and some of the critical alerts that we know are tied to specific medical conditions, we can also kind of do some estimates on potentially, if we had not caught any of these things and the worst case scenario had happened, which again we know would not happen 100% of the time or to all of these individuals. But if we just take the high blood fats, thyroid disorder, diabetes, and hypertension and calculate out what the potential claims costs could have been had those gone undetected, untreated, it's about $3.7 million potentially that could have been mitigated via the screenings. And again, I want to stress that we're not saying we saved $3.7 million. We're saying that potentially those are things that could have been incurred had folks not gotten detected in treatment for those alert situations. So on the next page, on page 6, really the bottom line is, we believe that obviously the alert values and the finding of those things in and of itself is of huge value to the district and to your employees. But we also believe that we would like to expand and really look at interventions past the screenings as we move forward to really give a more robust type program to your employees. And really, once we've identified folks, that's really when the work begins, is really being able to work with these individuals and coach them and help reduce risk factors over time. On page 7, a couple of metrics I wanted to share with you over time. You can see, again, from several years of or several different screenings worth of data, we are showing a reduction in waist circumference, which is good. Again, we still have work to do. But we have taken, from where we started, we had 58% of folks that had a high alert waist circumference. We're down to 53%. And on the folks that had a low risk or good optimal type waist circumference measurement, we've gone from 42% to 47%. So I definitely think that's movement in the right direction. Again, I'm not saying we're where we want to be, but that's definitely movement in the right direction. On the next page, on page 8, this really just gives you the total numbers of folks, and this is a matched pair analysis. So basically what we're looking at is individuals, specific individuals that have had the screenings, our screenings at least twice. So in other words, where did they start and where are they now, sort of picture. And again, at the bottom, you can see there's some initials. The LL in the green is those that started out low risk and have maintained low risk status. And so forth and so on, from the lighter green, from high to low, and then low to high, and then high to high. We're not winning on all of these fronts, but what I can tell you is, again, we're getting folks, some folks have been moved from high risk to low risk, and we're keeping a lot of your low risk people where we want them to be. Again, there's still some folks that were high to start with and are still in that high range. So we still have work to do, but definitely you can see that the number of folks, just numerically, from time 1 to time 2 has gone down about 135, 40 people that have actually improved waist circumference since we started. On page 9 and 10, let me explain to you a little bit about the CDC LeanWorks report. One of the things that we're able to do for our groups is to plug in your average salary for your employees. We're able to plug in the number of individuals that were screened in each of the different body mass index categories. And the CDC's tool then can extrapolate for us basically the impact, potentially the medical and work loss costs associated to obesity for your group. So these are your numbers from BISD folks that participated in health screenings. On page 10, if you'll look in the kind of the midsection, what you can see under total medical and work loss costs attributable to high BMI, there's actually a total of about $5.2 million that, again, according to the CDC data, is costs to the district that could be attributable to excess weight. So this is not just medical costs, but it's, again, workers' comp, it's absenteeism, presenteeism, all the different factors that are impacted as a result of obesity. So I think what I put this report in for you because I wanted to illustrate the fact that, again, working to get people's waist and weight going in the right direction has a huge cost-saving impact for the district over time. Page 11. Page 11 goes over a metric that we have been tracking for you, and we track for all of our groups, that I think is really very, very important, and that is metabolic syndrome. Some people refer to it as prediabetes. Metabolic syndrome is basically a clustering of risk factors that if you have 3 or more of these factors present simultaneously, it puts you on the fast track for both heart disease and diabetes. Studies have shown that if you have 3 out of 5 of these present, that your risk for heart disease doubles and your risk for diabetes, type 2 diabetes, goes up 5-fold compared to somebody without these risk markers present. So when we look at the district and how you scored, the population scored, out of just over 5,000 folks that were screened, there are 1,460 individuals with metabolic syndrome. These are folks that, in the best case scenario, what we want to do is not only identify that they have MET-S and counsel them on lifestyle factors that can positively impact their markers, but really we want to outreach and coach these individuals and really make sure that they're connected with their physician and really engaged in their own health to prevent heart disease and or diabetes going forward. You can see that there's 158 of those individuals that have all 5 markers present. So generally what I would say is these are the kind of the ticking time bombs, to be honest with you. These are folks that there is much to gain by outreach and engagement with this population. And again, these are folks that, if they don't already have the diagnosis of heart disease or diabetes, are headed down that pathway. On page 12, you can see the trends of MET syndrome over time, again, since the first time we screened here, and we have made some improvements. We have reduced the number of individuals that have 4 and 5 risk markers. And we've increased the number of folks that have the 0, 1, and 2 risk markers. So we're moving people in the right direction slowly but surely. Again, I think that just illustrates the point that, we've just scratched the surface on what the capabilities and the opportunities are in assisting these members and then thusly assisting the district. Page 13 goes over blood pressure findings, another area that we've made some improvements in over time. From the first time that we have screened, you can see that good blood pressure readings, or readings in the normal range, have gone from 37% to 44%. Moderate risk readings have gone from 45%, to 39%. High readings have gone down by 2%. They're now down to 16%. And alert values, again, have gone down from 1% to really 0. Again, when you take the total number of folks we screen over 5,000, it comes out to near 0. So basically, we're making some improvements in both waist circumference and blood pressure, but still a lot of opportunity for further improvements. Page 14. On metabolic syndrome alone, there's been a lot of research done on what the cost is, or what the potential cost is to your health insurance if you have MET-S, if you have metabolic syndrome, and or you become, and the likelihood of which you would be diagnosed with one of the chronic conditions associated with MET-S in the near future. Again, if we look at diabetes, the incidence rate for people with MET-S in the next 3 years, 18% of them will be diagnosed as full-blown diabetics. 15% will be diagnosed with cardiovascular disease. 48% will be diagnosed with full-blown hypertension. 5.3% of those individuals will have a heart attack, and 1.4% of those individuals will have a stroke. So again, if we extrapolate the cost of treating those conditions and the number of employees that fit each of these different criteria based on the data, that's about 11.3 million over the next 3 years that potentially that particular population of folks with MET-S could incur as a result of their risk markers. On page 15, I'm sorry. That's it. Page 14 is it. On page 15, there's more to come.
Yeah.
So bottom line, really, I think what I want to illustrate to you is that you're making some steps. We're definitely making some steps in the right direction. There's still a lot of opportunity out there. And we'll continue to visit with the district about ideas and solutions for the future. We love working with your employees. I think that the employees appreciate that they have this service available to them. And clearly by your participation rates year over year, this is something that's a very valuable service to your population. Any questions?
Questions or comments from the board? No? Thank you very much
Thank
for the
you very much for the
Peña?
information.
Well,
I
you're
just
welcome.
want to thank her because I love your spunkiness, your enthusiasm, and that's what helps people get to where they are and keep that going. And we're very blessed that we have someone like you, because that's what it takes to encourage people. And every time I see you, I get all encouraged to get in shape, do the right thing. So thank you.
Thank you, ma'am.
Well, that's why we're here. Thank you so much for your time.
Moving on to item 4, overview of workmen's compensation program. Dr. Montoya.
Again, we have some information here, Mr. Garcia.
Yes, thank you, Dr. Montoya, Dr. Escobedo. At this time, I'm going to ask Mr. De Leon to step up to the mic and introduce our presenter on the overview of our workers' compensation program.
Good afternoon, Board President, Dr. Escobedo, Dr. Montoya, board members. As you know, the workers' compensation is a state-regulated insurance program that pays for medical bills and replaces a portion of an employee's salary if that employee is injured while at work or has a work-related illness. Currently, BISD provides a self-funded workers' compensation program. We are currently going out for bids for the TPA self-funded workers' comp program and excess insurance because our current contract for our current TPA has exhausted its options for renewal. The RFP is 13034, and so be expecting it this coming month. The current TPA is TriStar Risk Management. They have served the district for the past 8 years, and I'm going to introduce Mr. Jimmy Dyer. He's a representative for TriStar, and he's going to be talking about usage, claims paid out, claims by department, and maybe some other things. Mr. Dyer.
Thank you, Mr. De Leon. Dr. Montoya, President Escobedo, members of the board and staff. We're here today to kind of give you an overview of the worker compensation program. And to start that off, I think we need to go back in 2003 when the governing body that was here at Brownsville ISD was faced with a $8 million plus insurance premium. And the board at that time and staff elected to go self-funded. And in the first year, we had claims cost of about $2.2 million. But overall, the district in the first year, I think, saved well in excess of $5 million by electing to go self-funded. Since that time, in year two, I think you had $2.4 million. And then I'm kind of giving you a slide right here that kind of gives you the last 5 years. And probably our best year that we had as far as claims cost was concerned was in 2007 and 2008, where you incurred claims of a little over $1.2 million. Since that time, we did start seeing an increase, and it peaked out in 2009. But at that time, the board approved bringing on board a certified safety specialist. The CSP is the acronym off of that, to work with district staff and the departments to do some training, evaluating, and see if we could help reduce the cost. You can see after the first full year, your losses went down to 1.5, almost 1.6 million again, but at least now they're starting to trend back down, and we think a lot of that has to do with the effectiveness of being proactive in education and training to be safe in the workplace. So far this year, we seem to be coming in a little bit less than last year. We still got a lot of work to do. But at least the trending is now kind of going in a more negative fashion. We really classify claims as they come in into two categories. One is the indemnity, and that's where you see the large red line there, and that's where your big costs are going to. An indemnity file is one that's turned in when an employee has a pretty serious injury that will likely result in lost time from work or a permanent impairment. A med only is kind of the way it describes. The employee gets hurt, maybe they go to the doctor once or twice, and then it closes out. As you can see, the indemnity costs have been going up. The variety of claims on the next slide, as you can see, in 2007 and 8, we had 360 medical only, which were really minor claims, but we had 258 indemnity type. And 0809, 287. Then in 2009, we had a slight downtick, which kind of correlates with the dollars spent, to 279 claims to 244. And thus far this year, we've only had 89 claims that fall into the indemnity category, which is a significant drop from prior years. So the total numbers of claims seem to be trending down a little bit this year as well, but the vast majority of claims are in the medical only category. So where are your dollars going when we do pay claims? We have three categories that we pay. Obviously, we pay medical benefits, we pay indemnity benefits for wage replacement, and then an expense is where your legal, if we use a private investigator or independent investigating firm, those costs would be lumped into that category. So by far, roughly 70% of your dollars are going into paying for medical benefits to your injured workers. And so that would kind of some areas where we think we might be able to focus some ideas and concepts, like developing your own workers' comp network for your employees to treat. There's a couple options we're looking at right now and discussing with staff to see if there's a way to try to still improve the quality of treatment for your employee. They have adequate choices, but yet still try to control your cost. The next category, kind of where your claim's going. what departments or what areas are reporting claims. And here are really the top 10 as we took it. Staff wanted to see what the top 10. Food service and custodial and transportation maintenance, that's pretty much with all school districts that I do work with, that they fall into the more high category of just by the sheer nature of their work. But in this case, food service, and this is from October 1st, 2009 to present. So it's roughly 34 months, the last 2 full years in the current policy year. 98 claims in the projected cost. This also, when I say cost, this is not already in paid claims, but it's paid claims plus what we anticipate future claims to come in. We call it a reserve for projected cost until the file will close out. And so you have 98 claims, 485,000 and some change, roughly a cost per claim of $4,956. Your next area is the custodial, again, relative to that, but they have 91 claims, but their cost per claim is significantly less, $1,887, transportation and so on and so forth. And then you get where your high schools seem to be where you have some additional claims. So you kind of got the total dollars, the number of claims, and then I gave you an average cost per claim so you can, so severity in the food service could be an issue, something we may want to look at. Not necessarily that they're a problem, but that's just where your dollars are going.
Dr. Saavedra?
I have a question, sir.
Yes, ma'am.
On these schools, could you identify what most of the injuries were?
I
Or
mean,
what the claims were?
we can break that down. I mean,
Well,
most of
just, do you recall off the top of your head were they falls? Were they?
well, that's my next slide that I have here. A vast majority of your claims are in I would say a fall, slip, or trip type of condition. Body motion, that's kind of be twisting, bending, that kind of stuff. Even have a couple of falls at the same level. So we do try to work with our staff because when they code these files, we need to make sure we're trying to be consistent so we can, from a loss prevention area. But I think we've been focusing on, with the certified safety specialists, on identifying work areas that have problems with, if is it a slippery floor, a custodian mops, and then he walks through there and slips and falls and those types of things. So we're working with the safety specialist to try to identify those types of things.
So before you go on your previous slide, would we have any indication or idea as to why there would be a significant difference between one school from another, say Pace and Rivera?
I don't know. I mean, we can break that down. I couldn't tell you. I thought it was ironic because with some of our other clients, I usually see middle school instead of a high school, but here it's just what was reported. In like food service could have been in a Pace High School or that too. So we kind of group the way we code things. We group everything together.
These are just the schools, not the clusters, correct?
It's
Yes.
The campus.
The
the
campus.
schools. The way we got it set up for coding. Yeah.
Thank you. I'm sorry, you may continue.
Oh, okay. Well, again, I really don't have much else. I kind of.
Okay, go back on.
You want to go? Everybody's stuck on this slide. Okay.
Yeah.
I'm sorry. Was there a question or?
No, so you may
we were-
continue.
We were discussing
Oh,
that
okay.
if there are these many, I guess, this.
And I'm also concerned, like you have one elementary, out of 30-something, Paredes
Yeah.
Elementary. Is
Well-
there something about that elementary that maybe we should focus on, and something going on there that's not happening in the rest?
If I may,
Peña?
I'm just looking at this, and I'm wondering, it's on here because maybe what happened or the injury that happened to happen at that high school brought these costs up. So is it individuals that get injured and have these claims, and it just so happened that, like that individual had a costly injury?
It could be, and
And
it
it's
could
not that
continue.
it's a school. It's like, for example, I fell in a hole and tore my foot off my leg, and it just happened, right?
Right.
So if something like that would happen, then it goes under the school, but maybe not to say there's something wrong in the school. It was just an unfortunate incident, and it cost the
Costly.
district.
It cost. This is driven. The top 10 is driven by the numbers of claims they reported. Not necessarily. We could have had some other campuses that only had 2 or 3 claims, but they could have had $100,000.
Right.
This is just being driven by the numbers of claims. It's just a kind of a snapshot, not necessarily where the worst claims came from.
Are the numbers.
I mean, you could have had at this elementary, they could have had 22 very minor claims, and somebody came in with a herniated disc back and kind of distorted the dollar amount.
Yeah, okay, that's what I was thinking, okay.
In essence, that's really all I have, is just kind of give you a snapshot there where, you know, we want to continue to work with you guys. We think we've made a lot of progress, and the district has literally saved millions of dollars since going self-funded. One other thing that I would like to say is that the state audits all self-insured or carriers in the state, and Brownsville was identified for where they call it a performance-based objective, PBO audit. And the preliminary results is that your score is going to be the initial score was 94.65%. So we feel pretty confident. We're going to dispute some of the findings that they said were late that discounted it from 100%, but we feel pretty confident that you're going to be labeled top tier by the state by the end of the year.
Now, another question, you know, this is great information, thank you. When a lot of us think of workman's comp, we kind of, in the back of our minds, think of, you know, the potential abuse and fraud.
Right.
And you kind of touched on it very lightly, but what is it that we're doing to be proactive to try to minimize it as much as possible?
Well, there's several, you know, proactive in the sense of if you can prevent an injury, that's the best way to do it. So that's why we have
prevent fraud and abuse.
The fraud and abuse, that's where we do, through the district, we do a lot of personal investigations on people. So if it's a questionable one or one that kind of falls outside of the norm, we actually have a person that goes and interviews to really give us more information about it. I mean, we're not here to abuse your people, but we're here workman's comp is to cover occupational illness and injuries. And sometimes that gets a gray area that gets over that maybe it should have been in the health, you know, or your wellness program, but people can make a claim that it's work-related, and that's our job to investigate it and to make a proper determination and, you know, treat your people fairly. But the program's been pretty successful.
All right. Any other comments or questions, Mrs. Longoria?
Dr. Montoya, I don't know if you or the gentleman can answer this. Aside from Mr. Orlando Cano, he's our safety coordinator here in the district, but I also understood or heard or something that TriStar also has a person that comes and provides safety training as well. Is
that correct, sir?
That is correct. The board approved back in 2009 when renewed. The staff had requested, and we provided a quote where we were bringing in a certified safety specialist, which is a.
So how much training has that person provided to our district?
I want to have to go back. I think it was like a couple hundred hours a year. It's really kind of minimal when you look at it, but and you could probably utilize more, but that's the savings of that sometimes is subjective. It's real hard to, like here we started in 2009 with the safety program. Your losses had been trending up roughly 10% to 15% a year, and after we implemented the program, it flattened and is somewhat trending down. Now, is that all because of the, you know, the safety specialist? You know, that's subjective to determine that, but what I think is training is a good thing, and reinforcing the safety mindset with your people is an ongoing. It's not just a one-time thing. It's an ongoing.
Yeah,
effort.
and this person was contracted for a year?
3 years.
For 3 years?
It coincided with our contract.
Okay, so our claims haven't really gone down. From the last year?
Yes, ma'am. Well, I mean, yeah, it didn't. I mean, it's not going up, but yeah, it trended down slightly. 50,000 in 2010. The year before was 1.641 million. In 2010-11, which was last year, your last full complete year, is 1.596, and so far this year it's 1.3.
Got some, but not that much.
Yes, ma'am.
And Dr. Montoya and Dr. Escobar,
Ma'am?
in our reality, I mean, and we do the training, but we do have to take into account that these are human beings made of flesh and blood. And some people will have a slip and have a severe injury, and or a minor slip, and other people can fall off a tree and walk away and go eat like nothing. So
Absolutely.
they're all individualized, so we need to take that into account. And the fact that it did go down some, does make a difference.
It's not going up, and with medical inflation and your population of your employee base going up, I mean, statistically, if your number of employees go up, chances are your number of accidents would go up with that as well.
Comments or questions of the board? Thank you very much, sir.
Thank you, sir.
Thank you.
Moving on to item 5, update on BISD self-funded health insurance plan. Dr. Montoya.
Dr. Escobedo, members of the board, Mr. Garcia, you also have another presenter.
Yes, actually, 5, 6, and 7 are kind of going to be intertwined. I'm going to start with the update on the BISD self-funded health insurance plan, and at this time, I'm going to ask Mr. Lance Penley to come and go over the presentation that is provided in the back of your handout here, and then we're going to touch some things there, and then I'm going to ask after that to bring in Ms. Ray Bailey and Cindy Sosa, which are representatives from Blue Cross and Blue Shield, to talk about some other options in there. So we kind of go over the lines between 5, 6, and 7. I'm hoping that you can understand, and we'll identify those components as we go along. So, Mr. Penley.
Mr. Penley, welcome. Good to see you again.
Dr. Montoya, members of the Board Insurance Committee, good to see everyone again. I'll go directly into my presentation, and I think we've provided you guys copies of the presentation, and I've got copies to hand out afterwards, or right now if there's somebody that does not have a copy of that. Table of contents, we're going to just briefly go through the executive summary of how the health plan's been running this year. We're going to talk about the immature claims, which, to remind you, immature claims are only Blue Cross claims. Those won't have any of the mutual assurance run-in claims included in those numbers. Then we're going to talk about the mature claims that include mutual assurance, year-over-year comparison. So where are we this year compared to last year when we were with mutual assurance? The network discounts that Blue Cross is providing, pharmacy cost, and then I'm going to stop right there and send it back to Mr. Garcia. On this first page, I'm going to go through this for everyone again, just in case there's somebody that hasn't seen this. We do an executive summary. So we show you the average monthly covered employees by the district, which is 7,447 individuals. That's the average monthly covered employees. Gross medical claims paid to date, so from October 1st of 2011 through June 30th of 2012, Blue Cross has paid $21 million in medical claims. We've only had $16,000 through 9 months in stop-loss recoveries paid by ING. So the net medical claims are $21,655,000. The RX claims paid by Prime Therapeutics, which is a partner with Blue Cross Blue Shield, is just over $4 million. The administration cost paid to Blue Cross at $1.7 million, and stop-loss premiums paid to ING just over $1 million. We also break that down for you on a per employee per month basis, and then a percentage of the overall health plan cost. Total expenses year-to-date through the 9 months is $28.5 million, $425.65 PEPM per employee per month, and that's 100% of the cost. This does not include the mutual assurance run-in claims, which is about $4.2 million, and we're going to talk about that here in a little while. So if you include the mutual assurance run-in, we're at roughly $32 million in total expenses for the health plan through 9 months. On the next page, this is immature claims. So these are claims only paid by Blue Cross Blue Shield and Prime Therapeutics through the first 9 months of the plan year. We have the month-by-month numbers. We also have it broken out by the 3 plans available to your employees. We have the core plan, the high plan, and the state plan. I've got that broken down where the enrollment numbers fall for those various plans. You'll see that a majority of your folks remain in the core plan, which is the plan 100% paid for by the district. You do the combination of those three plans, you go over and you can see the gross claims paid for both medical and RX is 21 million, which would be the same number as on the executive summary, minus the 16,000 that ING has paid in reimbursements thus far, and you get your net medical claims at 21.4. Then we've broken down once again the average employees per month and the total net claims PEPM. So this PEPM number is different than the first page because it doesn't include the administrative cost associated with your plan. The next page is those claims paid on a mature basis. So all we've done here is taken the Blue Cross claims at 21 million and we've added in the mutual assurance run-in claims. I'm happy to report that really Mutual Assurance is not paying any sort of run-in claims anymore. So I got another report from them here in the last week or two, and they paid roughly $1,800 out since April 1st. So we are really just running with Blue Cross Blue Shield at this point, which is positive. Blue Cross is delivering a very strong network discount on the claims piece. And we're going to talk about that a little bit further. I just showed you in a different way on a rolling 12. So we're looking at the three plans once again and just the last 12 months in those three plans, and then the combination of the three. It's just another way to look at it. You're still going to have, obviously, 3 months of mutual assurance claims in this rolling 12, as well as some run-in for mutual assurance in the last 9 months. This is a big page for us. This is a very positive thing. The board and the administration, this really shows that the recommendation that was made last August, August-September area was a good recommendation. Blue Cross, on a mature claim basis, has brought our claims down 18% per employee per month. So it's a real positive. Scott Gibbs and I, when we were making the recommendation to the board, estimated that mutual assurance claims were going to run at 48 million for the next plan year, and it looks like Blue Cross is going to run at about 34 million. So we're looking at a significant reduction in claim cost, and that's going to help the fund balance.
Peña?
Dr. Montoya, Dr. Escobar, what do you attribute to the claims being brought down, or for this significant drop?
Yeah, there's a number of things, but I think the thing that Mr. Gibbs and I looked at the most when we came and presented our recommendation to the board was the network discounts, which you were with Texas True Choice in the previous year. We did a very detailed repricing analysis, if y'all remember, and Mr. Gibbs and I showed you guys what we thought the claim projections would be under all the different scenarios. So the biggest piece to the reduction in claim costs for the district is, for lack of a better term, Blue Cross has just got significantly better contract negotiations at all the providers in the area. So,
and the reason I ask is because are they dropping this coming down because they're denying claims? And I say because there's a lot of doctors in this area who don't take Blue Cross, and I can't go see them for whatever reason. So I want to know the drop. Is it something that is effectively being done because we're getting discounts, or just the fact that if we don't pay that claim, well, that's just less claims we have to claim? You see what I'm saying? Yeah. I want to make sure that that's not happening, because there are doctors still in this area who will not work with Blue Cross, Blue Shield, and it bothers me because I'd like to know why.
And I understand your concern. I would say the most significant difference, like I said, is the network contract arrangements. There are doctors, for one reason or another, that won't accept Blue Cross into their network. It may be for various reasons, and Blue Cross is here to speak on that. But I'll tell you, a lot of times what we come across at McGriff when we get these arguments that come to our desk, we find that The doctors terminated voluntarily because they didn't want to accept the network contract arrangement that Blue Cross Blue Shield was trying to negotiate on the district's behalf. So,
And with that said, I totally understand that, but
Yeah.
even in your pharmacies, there's certain medications that Blue Cross says this are covered, this is covered, but only this works for a certain patient. Well, you have to go through a lot of red tape because they haven't been able to negotiate to something comparable with whoever's producing that particular medication. So I want to know if our people are losing out and having to go elsewhere, and being on the border, people just go to Mexico and get their prescription filled because they can't afford it here because it's being denied at the pharmacies because they pull it up and Blue Cross says, well, that's not covered by your insurance, but that's the only thing that works. Well, I'm sorry, it's not covered. Talk to them. And most of the time you talk to them, they deal with it, but they put you through a lot of red tape. And I just have a problem for someone on the other end of the line that doesn't have a medical degree tells you what your body needs to take to work. I just want to make sure that that's being addressed. And being that you represent Blue Cross Blue Shield, I bring this up because it's very critical to our employees that they get the medical attention that works and they need, and not have someone say, I'm going to tell you what works for you, and it doesn't always.
Sir, any feedback?
yeah, absolutely. It's and I'm glad you brought that up. Thanks for voicing that. There are going to be individuals that are affected from time to time on what I would call administrative type situations where they're prescribed one drug and then the pharmacy would prefer them to take a generic drug. I can't really speak to each individual specific situation, but I can promise you that Blue Cross Blue Shield has the district's best interest at heart, and they also are very they have the members' best interest at heart, and a lot of the things that they do. And I'll let Ray and Cindy speak on that later on if there's any additional questions. But as long as employee issues and concerns are run through the administration, the insurance department, and then those things are escalated up through Ray and Blue Cross, we can typically help individuals get the information that they need to make the right decisions and make sure they know that Blue Cross has their best interest at heart.
That's key, what you just said, having the school district's best interest at heart. I know a few local physicians do kind of complain a little bit that the reimbursements are just not there. And I've seen some of the numbers, and yes, they are. Some of them look like Medicaid reimbursements.
Yep.
But at the same time, I'm here to do what's best for the district, not for their practice. So that kind of puts me in a kind of a unique situation. But I think what you said is key. What's in the district's best interest, so long as it doesn't jeopardize quality of health, which I don't believe it has. But anyway, you
absolutely. And those providers, if they don't like the reimbursements that are negotiated on behalf of Blue Cross Blue Shield, they absolutely have the capability of pulling out a network. The problem is there's a lot of Blue Cross Blue Shield cardholders down here in the valley, and they're going to lose out on that additional opportunity of people coming to see them if they are out of network. So it's just a catch-22 situation, and like I said, Dr. Escobedo, I think Blue Cross does have your best interest at heart, and the employee and the member's best interest at heart.
Dr. Escobedo, do you have like a number where people can call you directly and maybe deal on an individual basis? Because I know that if somebody on the other end can hear why they need what they need, like say medication, when you go to a pharmacist, they'll tell you Blue Cross will not cover that one. So I heard you say the pharmacist wants you to take the generic. The pharmacist is doing what the insurance is covering. So to put it on the pharmacist and telling us, I heard you clearly say the pharmacist wants you to take the generic. The pharmacist will tell me, well, that's what your insurance covers. Well, that doesn't work for me. Well, take it up with your insurance because I can't help you because otherwise you're going to pay full price. Do you have a phone number that you can give us?
There's an 800 number for Blue Cross on the back of everybody's card.
And they can just call out that number to deal with them directly?
Absolutely.
Okay.
Continue,
But
sir, please.
I just want to correct that the pharmacist is saying what they're going to give you only what the insurance covers.
Somebody?
Miss, I don't know, may I ask Miss Peña a question?
Sure.
Is this person you're talking about a BISD employee?
It's, yes, they brought it to my concern. And I've asked them to call the back of the number. And I don't know, it's because they don't speak English.
Because I know the city also has Blue Cross Blue Shield,
Oh,
but
a
they
lot
might
of
have
people
a
in the
different
States.
plan. So just because it's Blue Cross Blue Shield doesn't necessarily mean it's our plan that we have.
Yeah,
They might have a different plan.
No, they work for the district, so I think they would have ours.
Or it
think
could be
they would
their
have ours.
husbands, that too, so. Okay.
Thank you, sir. Please continue.
Okay. I will go to the next page, and I'm going to just touch very briefly on this. If you look at the inpatient, outpatient, and professional charts, inpatient is when someone stays overnight at the facilities around locally. Outpatient is typically a day surgery, and then professional is your doctor visits, your primary care, your specialist, OB-GYN, things like that. Blue Cross has absolutely lived up to what they told Mr. Gibbs and I when we did the repricing analysis. They're running at about a 64% discount on their inpatient charges, a 64% discount on their outpatient charges, and then slightly lower at 58% on their professional charges. And that goes back to what I said on the previous slide. That is the major difference in the 18% reduction that you guys are receiving over the previous year. I'm going to touch very briefly. I know sometimes the Board Insurance Committee is interested in who their folks are going to see. I'll be happy to point out that every single one of your top professionals, meaning your primary care physicians and specialists, 100% of those folks are in network. If you look at the next page, the top hospitals, Valley Regional's the #1 hospital here in Brownsville for utilization. 100% in network on your top hospitals on inpatient. And then here we are on outpatient. The only folks that are out of network are Brownsville Kidney and Valley Baptist Harlingen Dialysis. And I'll tell you, it's very common for dialysis centers to be out of network. So that doesn't really surprise me at all that they're not contracted with Blue Cross. And the last page I wanted to touch on was the pharmacy. Just wanted you guys, the district employees should be commended. 71% generic utilization. I'd say the benchmark is 68. So by 71% of the drugs being generic, it's really keeping the district's costs down. If you see on the other pie chart, that 50% of the cost come from the brand formulary. So any uptick we can get in generic utilization means a decrease to the plan in overall pharmacy spend. And I know you guys are going to be talking about pharmacy PBMs here in a minute. I just wanted to throw some quick numbers out there. We're due to just a rough estimate at $5.3 million this plan year under Prime Therapeutics, whereas we were at $5.1 million under PTRX last year, which is a 4% increase. Trend increases are about 8% per year. So just my opinion is that claims are running very well under Prime Therapeutics. And I'm just going to send it back to Mr. Garcia, or if anybody has any questions for me.
Question on the board. So do we address the PBM questions to you or to somebody else?
I was going to send that to Mr. Garcia. I'm happy to comment on that, Mr. Garcia, if you want me to.
Let me, there is a little presentation from our staff on PBM, and then he's going to stick around because there's all the other discussion items. He's going to be brought in and out as to answer some of the questions.
Okay, sounds
So
good.
with that being said, now I'm going to ask Ms. Ray Bailey, which is our account executive, and she works real closely with us. And she has with her Cindy Sosa, which is the Director of Account Management for the Midwest Texas region, and they represent Blue Cross and Blue Shield. Now, the questions that have been asked are very good questions, and I think that they would be more appropriately addressed by this group of presenters.
Ladies, welcome.
Good afternoon, Mr. President and members of the board. Thank you for having us, and thank you for your business with Blue Cross. We really appreciate it, and I think for the most part the members are very happy, and I'm going to touch on some of your questions and your concerns there. The executive summary, I know Lance went over the majority of it, so I'm going to kind of skip through it, and I'll mention what pages I'm on. But if you go to page 2, I apologize, that's not a PowerPoint there. Page 2 shows claim expenses by claimant. It'll show you what tier they fall under. For example, the top portion shows claims paid. The first section, less than $200. You have 2,319 claimants. These claimants spent 1.3% of the total paid expenses, and the average paid expense per claimant was $99. If you look on the bottom, that shows the high claimants, which are over 30,000. These claimants spent 45.4% of the total paid expenses. The average paid expense per claimant was $82,980. So we do have several large claimants out there. Page 1.3. Network savings. You mentioned a contact person. We do have, the district does have an on-site representative for Blue Cross. We have Anicia. So on the website, y'all's internal website, where you have the benefits, if her phone number and contact information is not there, I will work with Mr. De Leon here to have it put on there. All the members have access. It's a point of contact for any member concerns. She'll work with our internal Blue Cross team to get it resolved. If she can't, she'll come to me and it'll be escalated, but certainly we do want to know about those issues. It's the only way we're going to be able to address them if they do come. But she is on site. She goes from campus to campus. She can visit all the campuses. They can just reach out, set something up, and make sure that she's there to educate the members, not only on their benefits, but on the member portal, any of the Blue Points, their wellness features, and get members a little more involved in any healthy activities. Also want to discuss the network. That's quite small. I know you had mentioned the network concerns. Currently, there's 99.5% members or claims that were paid as in-network, which will show you that in this area we do have a very large network. So you have almost 100% of all paid claims paid as in-network. Now, that's not to say every doctor's in the network, and certainly if there's one that isn't, we'd love to reach out to them to see if they want to participate in our network. That's definitely something that we can do. But for the most part, the members that are seeing doctors are seeing in-network physicians. I could also put together a comparison, if you're interested, of the different carriers and their networks to show you that Blue Cross does have a very large network in this area and throughout Texas, and members can also go out, throughout the United States for care. On this same page here, as he mentioned, the discounts currently covered, you'll see the inpatient, outpatient, and professional columns there. If you look over, you'll see the covered at $66 million. Our discounts were $45 million. That's a savings to the district. That was our discounts, and that totals to 68%. If you look over to the right, that's where you'll see 99.5% of those claims were paid as in-network. But again, if there is a concern, please reach out to Anicia or the health department, and we'll go ahead and address those concerns. Page 1.4. This report identifies the total medical and pharmacy member counts and their paid claims. And this is broken out by age and gender, by subscriber and dependent, so you can see kind of where your claims are falling. You'll notice the first area is on the males. And if you look down to age bracket on subscribers 50 through 64, you'll notice that's where most of the utilization is there. If you look over to the females, it's that same age bracket. So those are members that we can do an outreach program, maybe send some flyers, or you get in your preventive services, just different awareness that we can target that age bracket to get some more outreach. If you look at dependents under 20, on both the male and female side is where most of the utilization is as well. Do y'all have any questions?
No, ma'am, please continue.
That's it on the executive summary. I don't have a presentation, but it's this handout here. This is going to be a plan review, benefit comparison, and it's also going to include some comparisons to the surrounding schools in this area. Then we'll also have some recommendations. Thank you, Mr. Garcia. If you look on page 5, that's the enrollment and financial. And I'm skipping a few because it may be redundant. I know Lance covered quite a bit of that already. But just to point out a few items on page 5, membership and vitals. I have a comparison here. This comparison is the independent school districts that Blue Cross Blue Shield of Texas has. It's not of just the ones in this location. So if you look at your core plan, total average size is 1.38. Oh, I'm sorry. Average contract size is 1.38 for the core plan and 1.03 for the high plan, and the state plan is 1 point. So the total average contract size is 1.38, which is in a little less than the benchmark for our independent school districts that we have as a whole, which is 1.56. If you look at page 6 will go over the ICD-9 diagnostic categories. And we'll touch on just a few. These are the top 10 diagnostic categories for your district compared to all ISDs, a benchmark that we have with all the school districts that we currently cover. Your neoplasms, you'll notice BISD is spending $25.76 per member per month, where the other districts are spending roughly $19.80 per month. So there's a considerable difference there. Circulatory, BISD is spending $22.10, I apologize, $22.10 per member per month, where the other districts are spending $16.66 per member per month. The one that I found interesting was at the bottom, the musculoskeletal and connective tissue. This is normally very high utilization throughout our plans, but notice here how the BISD employees, they're at $10.54 per member per month, and the other districts are at $24.93. So that may also be part of the education that the members are getting, how to lift things properly, things of that nature. But that was interesting there. Neoplasms, the number 1 diagnostic category, which accounted for 12.4% of the overall per member per month, is 30% higher than the ISD benchmark. The top diagnoses were breast cancer, cancer of the lymph node, and lung cancer. Number 4 and 5 of high claimants had cancer of the lymph node. Circulatory, which is the second diagnostic category, there were 11 high-cost claimants with circulatory diagnosis. Page 7.
I have a question.
Yes, ma'am.
On page 5, where we have the core plan and the dependents, and I noticed that the total employees is 7,441, and then they have dependents 2,817. So I'm wondering, is it the cost, or Dr. Montoya, I don't know who can answer, is it the cost that causes our employees not to insure their dependents or their children? And the reason I say this, because I work a lot with children and recreational activities, and we have so many that are uninsured. What do you think is the reason that these families, I am shocked at the amount of families we have in the city that their children are falling between the cracks and they don't qualify for Medicare, or even they can't even get in the chips because they make too much for that but not enough for Medicare. So there's like a large group of children who are falling into these particular categories. And to me, if you don't have the medical care and go see a doctor, then the child establishes these illnesses, obesity, and all these problems because they're uninsured. And by the time they become of working age or do get picked up by insurance and they go see a doctor, they're like, what happened to you? Well, they've been not seen by a doctor unless it's catastrophic and they take them to the emergency room.
Do you have an answer, ladies?
I don't actually. What we can do, I know this year when we came on with BISD, the payroll deductions hadn't changed from the prior year. So I know they didn't increase, so I'm not too sure if that's the issue, but that's definitely something that we can take a look at.
If you would, I would appreciate it, because this is some way to be able to keep them from becoming a problem as they get older and come into an age group that they get on an insurance policy. That way they can get there healthier if they're seen sooner.
So if you can, please look into it and maybe let us know as soon as
Yes.
there's an opportunity.
Thank you. We'll go to page 7. This is a utilization summary, just trying to get a handle of where the utilization is. Is it inpatient, outpatient, professional services? It appears that the majority of the costs are in inpatient when we compare the costs versus our benchmark. And again, when I say benchmarks, that's all the ISDs in the Texas area, not just this area. I do have another sheet that'll show this area, but all the ISD areas. And the inpatient benchmark paid per member per month is 17.3% higher than our benchmark. So the inpatient utilization is a bit higher. Our outpatient utilization is 9.4% lower. So that's a good savings there. And the professional services is 17.7% lower than the benchmark also. Overall, per member per month, BISD is paying $2, it's $207.60 per member per month cost. The benchmark shows $218.12, which means your variance is a negative 4.8%. So the district is running very well. Inpatient facility on page 8. Just to break that down a little further, that was where the highest utilization was and the variance in the benchmark. On page 8, it appears that it's maternity that has the largest variance between the BISD plan and our benchmark. It's 30.6% higher than the benchmark. Now, you do have a special beginnings program, which is a great program here, and you have it for the members. That's a program where when they become pregnant, it's an employee or a spouse. They get into the program, and it's a program where someone will follow them. They'll ask them questions. If they need to be assigned a nurse at that time, they will. And they'll keep communicating with them, communicate with the doctor's office. So you do have this program for those maternities to try to contain those costs. Also, if the members participate in that, they do get an incentive. Page 9, high cost claimant overview.
Dr. Montoya, Dr. Escobedo, what's the incentive?
The incentive, if they participate in the program, that's from the time that they're pregnant, or it's actually, I want to say 36 weeks into their pregnancy. They call and register for the program and go through all the trackings, make sure they're checking in, keep up with their doctor's appointments, things like that. At the end, at the post, after they deliver, there's a follow-up, just to make sure everything went well. Do you have any questions? Do they need any training on breastfeeding or anything like that? So they go through the whole process, and that's the end process. If they complete the program, then their deductible is waived.
Oh, that's a good
So it's a
incentive.
very good incentive.
Yes, it is.
And it helps the members keep track of their pregnancies, make sure they're seeing the doctor, because they do, want to take advantage of that incentive. So therefore, we try to avoid any preemies, try to catch any high-risk pregnancies early on.
If I may, that's a good incentive. Do we have on our website where we can put stuff like this, Dr. Montoya, where people can become aware of it. As busy as we are in this world today, new mothers would really appreciate knowing about something like this.
Maybe we could ask you for some summary information with the idea of posting it on the website, because I believe it's not there, but we
Okay.
can make sure it is.
I'll double check, because I know in the beginning, it was posted, but there was so much, and, we were going through enrollment, and I know employees were just overwhelmed with information. I'll make sure that it gets reposted out there.
But, aside from posting everything on the website, how do these patients or employees find out about these incentives? Because there's no way we can post everything that's pertinent on the website.
You're right. That's where we're going to utilize Inicia, which is the on-site representative, to visit the campuses. If we can get reports based on campus to see what the utilization is in that area, if they're not taking their wellness exams, or if you do have a high amount of pregnancies in that school, then those are topics that she can discuss and have flyers there and just be there throughout the day so that teachers can come in or staff can come in and ask those questions.
Thank you.
On page 10, actionable insight. What this is showing, this is the BISD and versus the benchmark with ISDs in your area. So this is more specific to the Valley area. You'll notice that the neoplasms, the red is the per member per month variance. You'll notice that that is drastically higher than the claimant. So the cost of treatment for your neoplasms is a lot higher than the other districts in this area, and it may just be the types of cancers or where they're getting treatment, or there's different variances for that. Perinatal conditions, that's a little high as well, and that's where that special beginnings program and education is going to come into play. So I think that each campus would benefit from some education, on that. The hypertension, if you look over, was a little bit different. The cost is a little lower in your area than in the rest of the Valley area. However, you have more claimants. So that's something that we can educate the employees on. Make sure that they're taking medication. Actually, when with our systems, because you have the PBM, the Blue Cross Blue Shield, if we have someone that has diagnosis codes on claims that come in, and it shows that they have hypertension, but then on our pharmacy side, it's showing there's no medication being having them picked up. So our systems talk that way. So they'll definitely get outreach and say, I noticed that on the claim side you do have claims for hypertension. However, you're not getting any medication. Do you have any questions or their concerns? So that's where the education process will come in.
Question, slightly off topic, but I know that virtually none of these diseases that causes the highest claims are reportable. But I'm concerned, like neoplasms, that catches my attention. Even though they are perhaps non-reportable, would it behoove us to perhaps do some epidemiological work or consult with an epidemiologist to see if we can perhaps pinpoint something that's going on in our area or our district that's perhaps leading to these numbers?
There is. We have a medical director on site that I could reach out to, unless you have something different also. But we do have our medical director that I can take, that can analyze these reports and kind of get a better handle of what's going on and maybe what type of outreach, because it could even be as far as our diet, the certain types. So
yeah, because we need to see, if it's environmental, being where we are. I know for a fact, Dr. Escobedo, Dr. Montoya, that we have stuff that's coming in from Mexico in the atmosphere that there's no way for us to cut it off. And when that wind...
That's a conclusion that we cannot really say.
Well, you need to study.
And a lot of it is lifestyle related, so that falls right into wellness and prevention. But again, only an epidemiologist or an epidemiological team could probably help us with that. But anyway, that's kind of on the side, and please make a note of it because it is something of a concern. Anyway, for whatever that's worth, do you think that might be possible? You can consult with our medical director and...
I'm going to consult with our medical director and see how we could kind of pinpoint that or get a better understanding of that, and I'll be able to present that to you.
Thank you.
Page 11. This is just some recommendation on the neoplasms. We do have some early detection, some weight management programs, physical activities. There's also, once we do know of someone that is going through that situation, they have case management programs, utilization management. We can promote screenings, actionable plans. There's a tobacco surcharge. I know that different things to talk about on topics is different things we can do to help the district save money. And there are different ways that you can, make plan designs. You can offer incentives or disincentives to employees. You can add surcharges. Also for the maternity, we have prevention, prenatal care naturally, to manage your chronic conditions, nutrition management. For those programs, like I said, we have our Special Beginnings program, which it has the pre-admit and post-discharge programs. There's applications on their cell phone where they'll even text the mother or the expectant mother. She can even keep track of her contractions on there. So that's a great tool for the members. And again, that comes in with the education that Anicia can provide on campus. Actionable plans is for them to participate in that special enrollments, Special Beginnings program. Are there any questions?
Questions comes from the board? No, ma'am.
Page 12, preventive screenings. This was a little bit low, and I'm wondering if that is something because members wait till summertime to get maybe some of their wellness screenings done. But currently, the participation is very low. Cervical cancer currently at 24.4%, and the benchmark is 49.1%. So that's considerably lower. So we may want to do some educating there to the members, getting some information out about their cervical cancer screenings or any of their preventive screenings. We do send postcards to members based on their age or gender. They do get some wellness postcards sent to them automatically, but maybe there's more of a step that we need to take because it really is not being utilized, or it could be utilized a little more. The cholesterol screening, this may be just a little skewed because I know through personalized prevention they did have this done. It's just not in our medical records. The current is at 37.1% and the benchmark is at 54.6%, so they're considerably lower there as well. We do have a different program other than the personalized prevention, which is our Catapult program, which is very similar. They do go on site as well and they perform these screenings for the members. While they're there, the members will get their actual report there on site and have someone to talk to right then and there, have a professional to speak with. They'll also fax these results over to their doctor's office or when they come into our claim system. And if it is a cholesterol reading that was very high, then we'll start doing some outreach to those members as well. Colon cancer screenings, the current at BISD is at 8.7%. Your benchmark should be, it's at 20.1%. So again, that's considerably lower. Mammograms for females, you're currently at 20%. The benchmark is 47.9%. So again, all the health screenings are very low. So we definitely need to do some education there.
Peña?
And Dr. Escobedo and Montoya, I know like mammograms, for example, it's 1 or 2 years and it's low, but then we have, it depends on, I guess, our practitioners, because some say it should be every 3 years if there's no history or cancer in your family. So it depends on who you go to and what they're practicing per se. So maybe if we can get better education, especially for our females. And I noticed that the cervical cancer and mammogram, that's low, and that's something that some of these cancers, if you wait too long, by the time you catch them, it's gone.
You're right. Early detection is the main key. You're right.
And here's what the issue is: where we have people that are being told, no, you don't have to worry. You come every 3 years. But if you have a history in your family and that's not shared with your physician, he's telling you information that doesn't apply to you because you haven't shared all the information. So we can get more education now. We can get these numbers higher because this is preventive. Otherwise, it's going to cost us a lot to try and save them.
Right, and we do have the health risk assessment that members can go online and take, and when they take this, it's a series of questions based on their health, on their family history, and it'll, with the algorithms, it'll give them a report, and it'll show them, say, if they answer, yes, my mother had breast cancer, I currently don't, but it'll give a report that say how high their or even with just their habits, their eating habits or things like that, it'll give them a risk on how high their risk is for that cancer. And this is something that can be taken to the doctor's office so that they can, talk more to their doctor about it.
And where can you get that?
On the health risk assessment, it's available on the employee portal.
And it's on the, is it user-friendly?
Oh, yes, ma'am. Yes, it is. Actually, you'll see this one through the end of January, and through the end of December. January 1st, it's going to be updated, and I can tell you because I've seen the updated one. It's much more user-friendly.
Okay.
Yes. The one we currently have is a great one, but January 1, it's a step up.
And do we have a link on our websites to kind of educate people to go to these? Right, but it's, okay.
I believe there's a link to the employee portal.
Okay, that's
And
fine.
if there's not, definitely that's something that we can look at.
Yes, because a link makes it so much easier because people
Right.
just click. That's really
I agree.
user-friendly.
I agree. That's also an area where they can utilize that on their telephone. A lot of people have the smartphones.
Right.
So they can utilize that information online. They can use their smartphone. If they don't have their ID card, they go to their doctor, they can pull it up there and show it. So there's a lot of things that the members can use. A lot of perks for the members. We'll go on to page 15. And this is a page, pay to allowed ratio, and this is to show you where BISD is compared to some of the districts in the area as far as pay to allowed, and I'm on page 15. You notice BISD is where the arrow is. They're a little further to the right, which is the richest, which means you're spending a little more out of pocket on the plan side. Now the other districts, and this represents all the districts, and this is actually not in the Valley area, this is our Blue Cross ISDs. So you'll notice BISD falls a little to the right, which means claims utilization is increasing. And that may be due to some of those cancers, because we know those are the high risk, or some of those high claimants in general. So on that note, I do want to just point out some of the benefit comparisons that we've done in the Valley area, and that's on page 16. This is your core plan. The very top one shows the BISD benefits. It's the $500 deductible, $1,000 for a family. That's the BISD benefit. If you look below the ISD A through G, that's the different districts that Blue Cross Blue Shield insures in the Valley area. So you'll notice if you look down, y'all actually have the richest benefit. You'll have a $500 deductible compared to the others. You have one there that has $1,000, one that has $750. There's just one other school district that has a $500 deductible. If you look over at coinsurance, after your deductible, members have what's called coinsurance, and they pay 20% and the plan pays 80%. You'll notice on the other districts, the members are paying 30% after their deductible and the plan is paying 70%. So you'll notice there's a big difference in the coinsurance as well. The out-of-pocket max seems to be in line. Co-pays, there's only a couple that are lower than BISD. An emergency room, you'll have a very comparable benefit. However, y'all have a 2-tier RX, and that's been the same RX that's been in place. The others are just a little bit different. They have 3 tiers, and again, these are compared to the surrounding districts. On the core plan, just some recommendations if y'all were interested in making some type of plan changes, and this just shows possible savings to the plan. Network deductible to $700 from the current $500, leaving the family at 2 times, which means there's a maximum of 2 deductibles for the family to satisfy. That would be an estimated savings of 2%. So if you increase your deductible to $1,000, that's an estimated savings of 3.75%. So that's how, I won't go by each one, but that's how the grid works. And just to change the RX to a 3-tier program, it would save an additional 1.5% in claims. You'll see that on the high plan, which is page 17, BISD currently has a $0 deductible on the high plan. You'll notice the other lowest is a $500 deductible. And again, these are districts in the Valley area. I think the highest there is $500.
Do we know, Dr. Montoya, Dr. Escobedo, do we know what the monthly premium is for employees on these?
Do, but
The question was what, Mrs. Payne?
What the premium that the employees are paying when they want to insure a family? What's
For employee only, $154 for the high plan and $396 for the state plan. So the base plan, there's no deduction. And then the,
okay?
thank you.
Good to know someone knows that. Sad, not everyone knew it. Thank you. I should have known that. Thanks.
There's also very minimal differences in the out-of-pocket. They're all in the same co-insurance level, which is the 80/60. You have some at 50% out-of-network. Your co-pays are pretty much in line, 25, and the others, the lowest that's there is $15. Retail pharmacy, again, you have the 2-tier. A lot of the other school districts have gone to a 3-tier. And on the state plan, you currently have a $0 deductible, which there are a couple of other districts with a $0 deductible. Some go up to $500. BISD has a 90/70, which is after the deductible. Members pay 10%. BISD pays 90%. Some districts have gone to 80%. Out-of-pocket max, BISD is $500. The highest here for other districts is $1,000. Oh, there's one at $3,000. So as you can see, you'll have very rich benefits. So if you are considering some plan changes, we definitely do have options to help save the district money without risking the care of members, because your plan is very rich. And with any plan changes, because you all are currently grandfathered, you will lose your grandfathering status. So that's something that you all want to consider. I did want to mention that you would lose your grandfathering status, and I have Cindy Sosa here to explain what that means.
Good afternoon. My name is Cindy Sosa. I'm the Director of Account Management for Blue Cross. As Ray mentioned, you're currently a grandfathered plan. March of 2010, that's when the health care reform came into play. And any company that wanted to remain with their same plan and were able to grandfather their plan. That meant some of the provisions that came on board for the health care, they were not those provisions. Those provisions could be like preventive care paid at 100%, meaning that the employee would not have any cost share if they went into any preventive coverages. Then they would pay at 100%, or the plan would pay at 100%, and the employee would not pay any kind of co-payment or co-insurance. The other provision is emergency services. Right now, the benefit plan could have a different type of benefit if they were in-network or out-of-network, and this provision means that the cost share needs to be the same whether the employee were to go in or out. So that provision would kick in. And something new that just came on board is the women's preventive services. And this is also something that is without cost share for the employee. This is such as well woman visits, screenings for diabetes, which develops during pregnancy. The biggest thing is the approved contraceptive methods and counseling, and counseling for sexually transmitted infections. So that would also be covered by the plan by 100%. As Ray mentioned, you are grandfathered, and a lot of companies want to stay grandfathered because of the unknown health care laws that may come into play. So,
Definitely.
the way that you would lose grandfather status is what Ray had just mentioned. Any significant reduction in the benefits, such as increasing your deductible, increasing or the co-insurance or co-payment for the employee, and then also any kind of lowering of the employee's contribution to the plan. So just wanted you all to be aware of any of the factors that could go into play if you were to make any changes. You would lose that grandfather status. I also just want to make a comment and thank you for your support in the preventive services that you've had throughout the year with the wellness screenings. By doing this with a different vendor than with Blue Cross still helps your plan with keeping those claims costs down. So I thank you for that, and it's a huge support for your employees to have that in place. So I
agree with you.
You know, when we adopted or hired Blue Cross initially, I remember conversing with our consultant and Mr. Garcia. I felt very firmly that there was still significant savings in the pharmacy benefit management. That Blue Cross has their own. My question is, would it behoove us to explore an additional PBM? Does Blue Cross Blue Shield work with additional PBMs in other districts? Would you be the people to address, or Mr. Garcia?
Yes, actually, that's part of our PBM presentation, so if
Okay,
we're
well,
ready.
so 567 were like bulked up.
Right, it is bulked up,
Okay,
but,
okay.
you know,
Well,
kind
then
of
I
different
retract my
sections.
question for now.
Yes. So there's two questions that we have already under
Okay.
PBM,
Okay, great.
which is whenever we're ready.
Okay, any comments or questions for the board? Ladies, thank you.
thank you very much for your business.
I'm not quite sure what number we're on, but Dr. Montoya?
We're on 7 now, right?
Well, let me just make one, if I may, on 6, and then we'll go into 7, okay? I have some notes here that one of the things that I do have to say is that even though the plan is doing better than before because of the substantial discounts and things of the sort, the plan is still being funded. And that's something that we're going to have to look in the near future, take this year to really study it, look into, you know, working in either a plan design, improve benefits and contain costs, look into some contribution rates, and that's what I have, that's why I put their contribution rates. You know, we've talked aspect of it where certain groups would pay a certain amount, others. All that needs to be worked out. I know there could be some potential legal issues that we would have to address and things of the sort, but just to go on record, as we stand right now, the plan is being underfunded, especially when you take into consideration the medical trends, which are trending up. But, you know, it is a best improvement, but it is a work in progress that we need to keep front and center, and we need to address it.
Are we considering the possibility of changing the plan, or not to that extent?
Well, see, those are some of the options that we would like to explore in the future. I think that, as I said in the very beginning of the introduction, we're going to be looking at some possible potential future things, such as some items that are coming here, like things of this sort. So the other item that I wanted to stress is that this year our goal is to work closer with our employees to improve communication and our outreach. And I know that we have Mr. Rickme with us, and Mr. De Leon is now, you know, getting his feet more grounded. I know it was a new addition at the end of the year. So those are some of the areas where we're going to stress to improve. Those are some of the challenges and goals that Dr. Montoya has set for us for this department to improve in those areas, and that's our commitment. So with that being said, I'm going to ask Mr. De Leon to now come and talk about PBM, which is Pharmacy Benefit Management. We'll answer your questions about whether we can bring in another, or is there any flexibility on the prescription side. And I will also ask then Mr. Penley once to help us out with the presentation to answer more of the technical questions that might come up.
And real quick, before we start with the next one,
Yes.
on number 6, if I may, Dr. Escobedo, just make sure that we take into consideration our grandfather status, because we don't want to turn around and do something and it'll cost us.
That's correct.
And make very sure that that is not jeopardizing any way or manner for us. Because sometimes you're in a hurry to save money, you end up paying more. I don't want that to happen. Please.
Longoria?
Mr. Garcia, how much, can you tell us right now how much we're underfunded?
I don't have exact figures because remember we're looking at what was called premature claims and things of this sort. But my estimation, I'm thinking that it's anywhere between $30 to $40 per employee that we're underfunding the plan.
So whatever changes you make, it's not going to be to save money, but to recoup some of the money that we're.
Well, what the changes would be to continue, as you heard them, it's a really rich plan to continue, addressing the needs of our employees, yet not burdening them with additional costs, and also keeping the financial
Balance.
side on our side.
Yeah.
Since this is a self-funded plan, remember we are responsible for all the claims that happen under the plan.
Okay, thank you.
Yes.
Leon?
Mr. De Leon, we're ready for the presentation.
Hello.
Hi.
Board President. Sorry about that. Dr. Escobedo, Dr. Montoya, board members. Pharmacy Benefit Manager, PBM, is a third-party administrator of prescription drug programs. They are primarily responsible for processing and paying prescription drug claims. They're also responsible for developing and maintaining a formulary, contracting with pharmacies, and negotiating discounts and rebates with drug manufacturers. We are currently using Prime as our PBM, and that is part of the program with Blue Cross Blue Shield. The RX costs through June 30th of this year are running very close to last year. The 2012 plan year is running at $60.09 per employee per month. That's about a 4% increase over last year. Trend is currently running about 8% to 10%. Trend means that the cost of something today will cost about 8% the same time next year. It's another way of saying inflation. The 2011 plan year estimated at $57.53 per employee per month. With that being said, I'm going to probably bring up Mr. Lance Pendley to answer any questions that you all might have. Mr. Pendley?
Dr. Escobedo, before, can we get that information that he has just quoted out to us?
Sure, I can send that to you.
Thank you.
Bentley?
Mr. Board
Yeah,
President, Dr. Montoya, I'm here to answer any questions. I'm going to try to speak in real general terms and then also answer your questions directly, Dr. Escobedo.
Well, did you hear my question? Or do I need to repeat it?
Yeah, will you repeat it for me one more time?
Yes, sir. When we hired Blue Cross initially, you were the consultant, as you well know. I had the concern or the notion that perhaps an additional PBM or a stronger PBM program could actually save us significantly more. I'm not saying that we're doing poorly. I'm not going to argue that, so let's not repeat ourselves that we're doing okay. I know that we're not doing poorly. But is there room for improvement? And I recall when we made the award, I believe you had agreed, unless my memory is failing me, that about 6 months or so prior to renewing it, that we might consider going out for bids or proposals for a PBM. Of course, it's been longer than 6 months now, but is that something that is still, what are your thoughts in that regard?
Yeah, Dr. Escobedo, if I recall, last summer when Mr. Gibbs and I were hired, it was very late in the process. We did a very quick analysis, and we focused primarily on the medical costs. So looking at your current TPA Mutual Assurance versus Blue Cross and the other folks that bid, we did not do a very detailed PBM analysis, and that's something that at McGriff we do a lot of, where we'll actually take the same mentality that we do on the medical side, take a pharmacy claim dump from the provider, in this case Prime Therapeutics, and then go out and look at other vendors and see if the contracts are any different, if there's potential cost savings there. So we take the same approach to the PBM as we do the medical. We also come back and present to the administration and the board all the positives and the negatives surrounding something like a PBM switch versus working with the vendor that someone like Blue Cross is most used to working with. So.
And I'll give the analogy of a contractor. When we hire a contractor, virtually all contractors of significant size have their own project manager. So it's tempting to say we don't need a project manager because the contractor has their own in-house, and that's true to an extent, but I think experience has proven that when you hire an independent outside project manager, the project seems to be constructed smoother, and with significantly more savings usually. So that's an analogy that I can think of here with the PBM. Yes, we already have one, but with independent outside that does nothing but PBM, would they benefit us significantly more than the in-house that's kind of working with the Blue Cross? No, I think if I understand your answer, basically you're saying you don't know.
No, what I'm saying
is your answer.
Yeah, what I'm saying to you, Dr. Escobedo, it's my job to make sure that you guys are getting the best value for the money that you're spending, and it's very important to do a due diligence when it comes to the vendors, just like we do when we come and present to you the TPA, when we come and present to you guys the stop-loss renewal, which will be coming up very shortly. I'll be back in front of the board presenting the stop-loss renewal within the next 30 days. Life and disability, it's always very important to do a due diligence process to make sure that all the vendors that we're working with are giving us significant discounts on the drugs, in this case the PBM, and also that the value is there.
Right. Does Blue Cross work? I mean, obviously they're a large firm that work with numerous districts. I'm sure with many districts they work like us, just them solely. Do they work in conjunction with an independent PBM in other districts that perhaps we can kind of guide us as to whether it's beneficial or not?
Yeah, I know that we have a lot of business with Blue Cross Blue Shield, and in some situations we do carve out the PBM, so it's very doable. And I think that there's some districts around here, in fact, that do have the pharmacy carved out already. If I'm not mistaken, San Benito ISD has the pharmacy carved out. So in certain situations, it may make sense to carve that out. And like I said, we would do all that analysis for you and then come present to the Board Insurance Committee whether or not that made sense. I do want to present to you guys, just so that I'm being upfront with everyone, that Blue Cross does give us a discount off of our administrative fees for working with Prime Therapeutics. So they discount our admin fee on the current year at $6.37 per employee per month. So obviously, they're probably receiving rebates. I don't know the exact format of that, but they're receiving rebates from Prime Therapeutics, and in return, they are discounting our fees to the district. So if we were to pull the PBM away from them, we would have to consider the fact that there may be an uptick in administrative costs.
Sure, and again, we can weigh the pros and the cons. And again, I mean, I like your idea of analyzing it. I wish that there was a way of getting information sooner, because I don't know when we'll call another insurance committee meeting.
Yeah, Dr. Escobedo, I something like this, just to give you a time frame on something that we could get back to you. The process typically takes about 60 days just to get back in front of the committee with kind of some recommendations on what we thought we could do from a cost analysis. So, I know we're running up against this open enrollment period, and that's less than 60 days out. But that's something that we would commit to you and this board and the administration, is that during the next plan year, we could absolutely do that analysis for you.
And I'd appreciate that. And again, to Mr. Garcia and to you as well. I mean, not to be a tough negotiator, but if Blue Cross kind of cuts some of our discounts or benefits because of a PBM that could potentially save us money, maybe we need to try to renegotiate with them or go out for proposals again. Or, I mean, and again, not to be a tough negotiator, but again, we're trying to do what's in the best interest of the district. Mr. Garcia, I don't know if you have any comments or feedback.
No, other than we'll definitely look into it. Wrote some notes here, and we can come back and.
If I may, since we do have representatives from Blue Cross, may I pose a question to them as to, right off the top of their head, if they have any sort of comments or feedbacks?
Just some information. What we do is we offer you a rate of fee that we charge to administer your plan. And then because you're using our Prime Therapeutics as your prescription company, what we do is they get the rebates. And what we're doing is we're passing those rebates on to you up front. So we take your administration fee, we take your rebates that are going to you, we're passing the rebates on to you, so we're reducing your administration fee. So instead of waiting at the end of the year and then cutting you a check for the rebates, we're giving it to you up front. So it's really not a discount. So if you were to carve out the prescription to another vendor, then you'd still have our administration fee. You just wouldn't have those rebates that we're providing you up front.
Would we be carving it out or working in conjunction with, as far as the PBM?
Will you be carving out our prescription, and then just, if you were to elect another prescription company, then you would just add
It would
on?
not work in conjunction, then it's one or the other. Is that correct? Or am I making any sense? Sometimes I don't make sense.
I see where you're coming, Doc. There would be some coordination there between Blue Cross and the carved-out PBM, but like we're discussing today, it would be a third party that is not directly involved with Blue Cross. So there would be some file feed, eligibility, transferring back and forth. There would be a little less interaction on the case management side as well. So Ray was up here talking about, when somebody comes in with hypertension and we find out that person is not taking their preventative pharmaceutical drugs, there would be a little less coordination on that stuff. But it's not uncommon for pharmacy to be carved out when it makes financial sense for the client.
And I'm sure when you give us your analysis, you'll give us comparisons with other districts that have done what I'm trying to suggest, correct?
Yeah, we've got an internal list of clients that have pharmacy carved out, and we could also survey the Valley for you as well.
Thank you. Any comments or questions from the board? Thank you, sir.
Thank you.
Dr. Montoya, we are on number 8.
Number 8, again, the concept of clinics has previously been discussed, but it's resurrecting as a possible cost savings and a service to our employees. Mr. Garcia.
Yes, thank you, Dr. Montoya and Dr. Escobedo. Clinics, we're going to have a presentation. Again, this is the first presentation that we ourselves, meaning Ms. Trierigmi, Mr. De Leon, and myself, are learning about. We're going to present you with about 4 different scenarios and then ask for some direction from the board as to where is it that you would want us to proceed with this idea. It can be a cost savings to our plan. Note, as I said, it can be. It all depends on how you set it up, how you implement it, and then how it's utilized. So with that being said, I'm going to ask Mr. Rigney to come and give us a presentation on her research.
Good afternoon again, Dr. Escobedo, Dr. Montoya, Dr. Saavedra, Ms. Longoria, and Ms. Peña and staff. As a response to the request to give a report on clinical models, we met with several representatives from doctors' clinics here in the area who provide primary care services such as family and internal medicine practices, as well as specialty care and ancillary services such as lab, x-ray, and pharmaceuticals. We are offering 4 options. Option A would be to build a clinic from the ground up, purchase medical equipment, hire doctors and staff, buy malpractice insurance. It's a very high-cost option. The building itself would cost about $12 million. So that's not an option that we will be recommending. However, that is something that we looked into. Option B would be to rent clinical space, and the same scenario, hire doctors and staff, pay the cost of malpractice insurance for these medical providers. And in the preliminary study, we didn't obtain any actual cost for this option. However, it is also a very high-cost option. Option C would entail contracting out directly with primary care and specialty physicians to provide service with special discounts built into these contracts. Option D would be to contract with the community health clinics, which already have clinical space and provide primary and specialty care, as well as other ancillary services. The specialty services include women's health, pediatrics, family practice, geriatrics, behavioral health, and dental. The ancillary services would include radiology, lab, space for visiting physicians, and these clinics have been practicing cost containment measures since their inception because they operate as nonprofits and they buy pharmaceuticals through the state co-ops. BISD already has an ongoing relationship with the Brownsville Community Health Center to provide its campus care centers health care at both Skinner Elementary and at Lucio Middle School. Options C and D, because these clinics are already in operation, these would be the lowest cost to the district. Based on the findings, it would appear that both options C and D, would yield a cost savings to the district. As to how much the savings would be, we would need to do more research, and at this point, we would ask the committee for guidance on what options to pursue at this time.
I think that options A and B are kind of perhaps not the best. My personal opinion would be to explore option C and D because they have significantly more potentially cost savings than having to start from the ground up. Any comments, questions from the board? What would looking into this? What would this research entail as far as doing more option C and D? Who would perform that, or Mr. Garcia?
Dr. Montoya and Dr. Escobedo, if I may. Yes, if we were to pursue option C or D, which means either contracting out or using an existing network, for lack of a better word, what we would want would be, again, direction from the board and said, okay, yes, go ahead and study it. Do we study it on our own? Do we want to have like an ad hoc committee so that we can have some input into it? So we would be looking as to going out for a request for proposal, setting up the criteria to go out for request for proposal, and then analyze what each of the vendors that are out there could provide versus the cost versus the savings. I guess based on a quick calculation here, usually they're going to run, depending on how you set up your program, anywhere from $2 million, maybe all the way up to $6 million to bring in like a third-party provider to administer the clinics. Now, we would have, again, to work with someone, or we can work out on ourselves to come up with a plan design as to, is it going to be for, what kind of illnesses or emergencies are we going to be treating at these clinics, or we're going to be covering, prescriptions and things of the sort. So there's a lot of components that go in it. I know that our current consultants have experience in guiding the district or districts in putting proposals together. If this is something that the committee feels that we should explore, then I want to get the go-ahead so that if you hear that we are talking with either certain doctors or certain vendors, or there's requests for proposals, that all of us are aware of what we're doing, and it's not something that we're trying to do on our own. So I guess at this time the best thing would be is, yes, this is something that we would like for you all to explore. Then we can come back with, okay, this is how we're going to do it. That way there is, if we start hearing, out in the public, certain individuals from the school district, being myself or Mr. Trigme or De Leon, are talking to us about it, at least you're aware as to what we're trying to accomplish.
And I don't disagree with that. I know our consultants are familiar with it. I think it was in 08 or 09 we actually presented to us, right? Yes, you presented to us specifically on the clinics, and it actually moved forward to an extent. And then for whatever reason, elections or whatever, the direction changed. But I remain adamant that there is a potential benefit of significant caliber to us, and I don't want to let go of that idea so long as I can push it.
I've got a question on that.
Peña?
Just let's say it came to a reality, and we had these clinics, and they were established. Would this tie the employees that are insured under our policies or our insurance to have only access to that clinic and not have, and see, that's what my problem is always.
Mrs. Peña, I know exactly what you're asking, and that's always been an issue, and the answer has never changed. The employee has the right to go wherever he
Yeah.
or she chooses.
Yeah, no, that's what I'm
And
saying,
we
that,
need to just clarify that, because that's always a controversy for whatever reason, but the employee can go wherever he or she chooses.
and that,
That's
and
clear.
with that, yes, with that, I would back this project 100%, as long as they have options.
Mrs. Longoria?
If you don't mind, can you repeat C and D, because I couldn't hear you very well?
Oh, I'm sorry. Yes,
Can we get a copy of CND or that paperwork?
We can send you,
Please.
yes, we can
I
send you
can
that.
go ahead and send that to you.
Thank
yes.
you.
Option C would entail contracting directly with primary care and specialty care providers of services with special discounts being built into the contract. Option D would be to contract with community health clinics, which already have clinical space and provide not only primary care but also specialty care services such as women's health, pediatrics, family practice, geriatrics, behavioral health, and dental. Ancillary services with these clinics include radiology, lab, and space for visiting physicians. These clinics have been practicing cost containment measures since their inception because they operate as nonprofits, and they also buy their pharmaceuticals through the state co-ops. BISD already has an ongoing relationship with the Brownsville Community Health Center to provide its campus care center health care at Skinner and Lucio Middle School.
Right.
And all these options, whether it's A, B, C, or D, would require a third-party administrator? We wouldn't administer them ourselves, would we?
Well, that's where I'm, being and saying that's where I would need to do the research, because I would need to see that the plan design. What I want is approval from this subcommittee to go ahead and come back with a proposal, and what I'll do is start off with the 2008 proposal, study it, see what we can tweak to see if there were, what were the pros and the cons of those proposals, but use that model as a beginning, come back to the board, do a conference presentation, not necessarily in an insurance committee meeting unless that's the most appropriate one, and then say, okay, this is what the concept is, get some input, and then put it out for proposals and come back with a cost analysis. I think that's the only way that I would feel comfortable to recommend for it, or say, you know what, after really looking at it, it's not a good thing, or it is a good thing. I would need that flexibility.
Absolutely. Comments, questions from the board? I think it sounds that there's no objections to pursue the idea, so,
Okay.
ma'am, thank you.
Thank you.
Moving on to item 9, Agent of Record Services, Dr. Montoya.
Mr. Garcia.
Yes, thank you, Dr. Montoya. Dr. Escobedo, our final item on the agenda is the Agent of Record Services. And I'm going to ask Mr. De Leon to kind of briefly give us what is an agent of record, what are the pros and the cons. I know that Mr. Panley also, if you notice on his presentation, he was prepared to give his expertise on those areas. Again, at the end of the day, it really winds up being what is it that the district wants to do. And with that being said, I'm going to ask Mr. De Leon to go ahead and present on that.
Sir Leon.
Dr. Escobedo, Dr. Montoya, board members, that was my question. When Mr. Garcia asked us about the agent of record, I was a little unclear. It was agent of record for all products included, or just the basic medical or the health insurance? Could you answer that for me? Or?
Yes, sir, and I think I made it clear in my email that when I submitted the item, basically, we've had an agent of record for our group medical for many years, and then we decided not to potentially save money, and I don't disagree with that. My question was, how are we doing without an agent of record? Do we still feel we don't need it? Do we now, looking in retrospect, feel that we do need it? Pros, cons? I don't know if that makes sense.
Sure. No, that makes sense now. With the 5 months that I've been here, I've never had an agent of record on the self-funded, obviously. We have a representative from Blue Cross Blue Shield, and she answers all the questions that have come into our office pretty much on a daily basis. I'm not sure exactly what her cost is for the school district. It's implemented into the Blue Cross program. Of course, that would be needing a consultant because of the self-funded program. To be a consultant, you have to have either risk manager's license or consulting license, in which, we have neither. And that's by the Attorney General's office, I think, of 2007 TDI report. I currently am in favor of just the being without an agent for right now, until I learn a little bit more about how this works. So far, I think we've saved a little bit of money in cost regarding commissions. I believe 15% commission, I think, on the stop loss of a little over $1 million, runs about $150,000, if I'm correct. And the 1.75 cents, $1.75 on the agent for the commission or payment for being an agent of record on the self-funded runs a little over $150,000 as well. So we're looking at a little excess of $300,000. So we've saved some money to the district by making this decision of being without an agent. But again, I've only been here 5 months. Let me learn a little bit more how this works, and I can probably come back at you a little later in time with a better answer.
Thank you, Mr. Garcia.
Right, and just for the record and to bring everybody on the board to date, last year was the first year that we decided to separate the agent of record services with the self-funded health insurance and stop loss. Now, I'm going to read here, because we did have a request for proposal at the beginning of last year to see what those services were that were being requested from an agent, and then what the costs were, which are basically right on target with what Mr. De Leon said. And these were the specifications on the service requirements. Provide ongoing services to administration and employees to assure overall plan satisfaction. Assist district in troubleshooting claims, eligibility, and contract issues. Review, analyze, confirm, and advise regarding self-funded group health plan, stop-loss life, and AAD&D. Assist with the implementation and evaluation of the BISD self-insurance health plan for the 11-12 school year. Provide on-site support to employees and administration during peak enrollment periods of August to November. Assist district with post-open enrollment issues. Provide ongoing analysis and report of the programs as requested. Meet and present with the Employee Benefit Committee, Administration, Board Insurance Committee, and the Board of Trustees as requested. Assist with administrative aspects of implementation of selected plans. Develop communication and provide on-site training that will help employees understand and utilize benefits and programs, and assist with wellness initiatives. Those were the services that we were requiring. I think that these services are being currently met by our existing personnel. I know that it is an area where we do need improvement, but you have to keep in mind the cost of it. And as Mr. De Leon mentioned, on the stop loss, approximately of $1 million at 15%, that's $150,000, and then $1.75 per employee on the self-funded health group insurance. That's 7,500 lives times 12 months. That's another 157,500. So the total savings on the plan was 307,500 roughly. At the beginning last year, when I became the CFO and we talked about going without an agent of record, I did have my reservations because it's something new and it's something that I didn't really see, exactly experience how we could manage it. But 1 year, almost a year into the plan, with now Mr. De Leon and also working real closely with our Blue Cross and Blue Shield partnership, we've been able to do it without an agent. Again, at the end of the day, is it good to have an agent? Well, there's advantages and disadvantages. If we can afford it, it would be a good thing. If we're still in cost containment, which at this point we still are, I think that we should proceed with the way we're going until we either have additional revenues, or we come up to an area where we really say, you know what, we're in over our heads, guys, and we really need some additional help. But if this were the service requirements, I feel that we are meeting them. Yes, there's room for improvement, and we'll improve it again. And you know, I say this, and I say it sincerely. This is some of the areas that Dr. Montoya has been working with us and saying these are the areas that I want you to see. I want to see improved in our insurance department, and we're going to work at it, and we're going to make it happen. So at this time, if you're asking me in short form, I think we can still continue without an agent of record, but by all means, if we do feel differently after some more analysis, we'll come back to the board and say, you know what, we need it because it's not going well for us.
And I don't disagree with that. I just hope that when we realize that we need one, it's not because there's been, you know, damage done or significant losses. That's my concern. I mean, I understand everything you're saying, and I don't disagree with you. I'm just a little nervous, and you know, I like your answer, Mr. Leon. I like yours as well. Comments or questions from the board? Thank you.
No.
Thank you.
No, I was going to say thank you, Mr. Garcia, because I know that that's basically what we're looking at. And if we're managing what we have and we don't have that manager there, the risk manager, then we should be okay.
The agent of
I
record.
mean, the agent
Yeah.
of record,
Yes,
yeah.
ma'am.
So, yeah, we have the risk manager. The risk manager
Yeah,
can look
he's
into
okay.
it and make sure, yeah, he's okay. But just alert us, and if he can do the same, because I'm sure it's the communication, and I think that's what Dr. Escobedo is alluding to. Don't keep us in the cold and wait. I mean, the minute you find out, let's bring it up, and let's bring it up for discussion, because if it requires immediate attention, we need to take care of it ASAP.
And with that said, Dr. Escobedo, it's true. The board doesn't like to be kept in the dark, because when it comes to light, it seems like things just don't go well. So thank you that you keep us abreast.
Comments or questions? If not, we move on to item 10, public input. Anyone in the public has comments to present?
Good afternoon, Dr. Montoya, members of the Board Insurance Committee. My name is Patrick Hamas, and at least for this part, I'm speaking on the behalf of the Association of Brownsville Educators. I'm just going to go off of some of the notes I have. Dr. Escobedo, you mentioned earlier, how does the information get back to the campuses? That works through the EBC, the Employee Benefit Committee. We have our monthly meetings. We have notes taken. The notes are sent to were sent to the insurance person. The representatives on each campus would also send a copy to their campus administrator, and that the campus administrator is then supposed to disseminate to everybody on the campus. So that's one way of communication for you, sir. On the dependent coverage that Mrs. Pena brought up, I would ask you to check on how many classified employees actually have dependent coverage, actually the numbers and the percentage. Most of them can't afford it. Okay, that's why they don't have it. On this part, talking of tiers and plans, that the Employee Benefit Committee talked about that. But under this current administration, a year ago, we're no longer involved in the health insurance. We're just on the voluntary insurance products. But we had talked about doing and reviewing that and coming back with recommendations to administration on how we could possibly tier it to make it more cost effective. But again, administration's recommendation was not to involve us on the health insurance side. On Ms. Pena's comment about accepting Blue Cross Blue Shield, being on this committee for a very long time, you're never going to make everybody happy. Doesn't matter if you have Mutual Omaha, or you had HealthSmart, you have Blue Cross Blue Shield, anybody in between. There's always going to be somebody who's going to be happy. Not everybody's going to take everybody. We understand that. The part on the prescriptions that Dr. Escobedo brought up, I think we need to step back about a year ago. A year ago, we were in a world of hurt. A year ago, you're looking at $48 million for health insurance. Possibly 50 was even mentioned. Okay? We didn't have hardly anything in the reserve fund for insurance at that time. Prescription costs, why? Because of all the situations going across, it was the utilization of prescriptions that have driven the cost up. Utilizations have gone up a huge amount last year, and I'm sure Lance can probably provide the documentation again on how much it had gone up. Okay, that's obviously proof. These guys have done a great job in bringing the cost down. The only part I differentiate with Lance on a little bit. He was saying 34 million, but it looks like going by the 28 million through 9 months, that's about 9.3 million a month that we're going through. That come out to about 38 million. Still a savings of $10 million. Tremendous job. But okay? Whenever we go out and do the 2-year contracts, they're usually front-loaded. We always do well on the first year of the contract. Keep that in mind. We tend not to get as good of a discount the second year of the contract, and almost always on the second year of the contract, the cost rises, and then we sit there and we point the finger at whoever, and then we go out for bids again. Okay, so I think we need to start looking at this on a long term. What are we spending over the 2 years? Okay, I would love to see the same numbers a year from now, even if there's a minor tick up, because it's still a huge savings. If we budgeted $48 million and we come in at 38, that $2 million savings, I'm going to presume is going to go into the insurance reserve fund. Is that correct?
It's public audience, sir. We will listen to your comments, but it's not discussion, it's public
Well,
audience.
meetings like this is unofficial. There usually is conversation in meetings like this.
We do. Back and forth. Yeah, we do back and
There are
forth.
dialogues and question and
I
answer.
never have, but I'm not gonna, I never
Okay, well,
have.
he's running the committee meeting.
Okay.
Sorry.
So that would be the question, because historically that's what you've done. We would hope you take that $10 million and put it back into the account. Another part where I may not be correct on this, on the co-insurance, I believe you pay on the co-insurance the same percentage that you pay on your insurance. So if you're on the core plan, you're paying a 70-30, then your share of the co-insurance is 30%. If you're on the state plan, you're paying the 20%, if you're on the high plan, you're paying on the 20%, and if you're on the state plan, you're paying the 10% of the co-insurance. I could be wrong that, but I believe that follows the same way as it does for our deductible or for our insurance. Had a question, and I guess it's not going to get answered, but you go back to Blue Cross Blue Shield. It's come out, and I believe it's August 15th, that that insurance companies will be giving rebates to large employees, large business employees, small and individual. Is BISD going to get a rebate? And if so, how much? And if so, where's it going to go? Is it going to go back into the general fund, or will it go back into the insurance reserve fund? But I believe those checks are going out August 15th, and that would be a question I think we'd like to know the answer to. Take off my hat for 1 second and put on the hat take off the hat of being an AOBE representative and put on the hat of being an EBC member. Clinics. Clinics came up about 10 years ago, maybe 12, when Mr. Lehman was still on the board. It didn't pass the first time. The employees were afraid of the cost. Okay, the cost, same thing, startup costs were something that we were all afraid of back then. Then, under Mr. Gonzalez, the EBC was asked to go out and check for clinics again. There was a subcommittee, which I was not a member of, that went and viewed clinics in San Benito and up the valley, came back and reported on what they saw. And pretty much, with Mr. Gonzalez present at the meeting, I remember it was a January meeting, it was unanimously, again, not to recommend clinics. So the key is if we're in a budget crunch, can we afford the startup? Is it cost efficient? Okay, if you're going to ask the employees, we'd rather have the raise. Take that money that's going to cost for the startups, put it into the money we talked about, give us the raise that was talked about. Okay, so on that's if we're looking at if you can show a long-term savings, I'm sure we'll go along with it. But if you're asking on the short term, and you're talking $2 to $6 million on a startup, take the $2 million to $6 million, put it towards the money for a raise, and give that to your employees instead. I'm sure they would thank you, and they would really, really appreciate it. I'm hoping in the future we can have dialogues. They've been very beneficial to us in the past. Thank you.
Would anyone else like to speak under public input? Please just state your name and your comments.
Dr. Escobedo, Dr. Montoya, my name is Richard Garza. I am with ISD Managed Care Services. I'm actually a policy congress for the National Rural Health Association, and we create policy for critical access hospitals, independent hospitals, FQHCs, and RHCs. I'm actually owner of 2 rural health clinics, so I am a health care provider, and I currently have the contract on the San Benito School District Clinic. So I wanted to share some facts with you, actually, to demonstrate the savings, the interpretation from the employees as far as appreciation. 75% of the San Benito School District employees that are under the benefits, the employees and the children, any dependents, get to utilize that clinic. 75% of them are currently utilizing it. We have a 98% generic drug ratio to that perspective. And the concept behind this is I heard the several options, and none of the options are set up with the model that San Benito is set up with. Not once did I hear bringing in a management company and actually running it and sharing the liability, passing the liability on. The concept behind it is currently right now you have great rates with Blue Cross Blue Shield. It's not the rates that you have, it's the medical community. We have the highest healthcare cost in the nation, okay? And this is nothing but caused by our medical community. Okay. The point is, with a actual on-site clinic, you're able to provide health care at cost with a little management fee on top. And when you're able to provide anything at cost, regardless of what it is, you save money, let alone when you're talking about an environment that's the highest in the nation. San Benito School District, when they started their clinic, from what I understand, they had a $600,000 budget cut from the insurance program. Since the clinic has been in play, they have not been in the red. They're currently in the black. They've taken the catastrophic high cost issues, our clients, from, I think it came down from 21 to 19 to 18 to right now they're at 3. Okay? The whole concept is access to care is basically what it is. Loss of time out of work. Two of the options that were mentioned were, the concept is for a VIP clinic, specifically for your employees, not to go negotiate a contract and do what they're currently doing now. I mean, they're sharing. They need a VIP. It minimizes the wait time. You're able to direct negotiate, for instance, cost savings, like you're interested in doing as well. And you get a practice, depending on who you utilize, the managed care models and concepts. The government has identified on a national level that there is a necessity for cost-save sharings. So they have ACO models for Medicare that shares with the providers, with the hospitals. Medicaid shares their models as far as cost savings with the physicians. And in the private sector, which you fall under, there's really no shared cost savings that are provided to you as an entity. And so the cost of a clinic, for operational is around $700,000, not $2, $3, $4 million. My perspective on this is more from a business perspective and not a medicine perspective. Nothing we can do in this industry can compromise the quality of care. Opening up a clinic, managing it, it's more beneficial for your employees. It can save you, I saw your numbers, millions of dollars instantly, short-term and long-term. So, no, you're not asking any questions or answering any questions, but if there's any questions you might have, I'll be free to answer.
Thank you very much, sir.
Thank you.
Anyone else like to present your comments? If not, this committee meeting is adjourned.
Good afternoon, everyone.